Assalamu alaikum. My name is Dr. Stan. I am presenting to the topic of our discussion is extracorporeal shockwave lithotripsy. In this diagram, we can see there is a large stone in the pelvis, but this stone could not be passed via ureter. But if somehow we will break the stone into many pieces that can easily pass through the ureter, and without any surgical intervention or invasive procedure, we can make this kidney stone free. First of all, we will briefly describe the introduction of ESWL. The concept of using shockwave to fragment stone was noted in the past 1950s in Russia. Dornier, a German aircraft corporation, discovered that shockwave originating from passing debris in the atmosphere can crack something that is hard. Shockwave lithotripsy revolutionized kidney and ureteric stone treatment. The great advantage of shockwave lithotripsy is its ease of administration as outpatient procedure, the absence of any requirement of general anesthesia, and its low complication rate. The first clinical application with successful fragmentation of renal calculi was in 1980s. There are four components of extracorporeal shockwave lithotripsy. First, we will discuss the energy source. Then, after energy source, we will briefly describe the focusing system. Then there is a coupling mechanism, and at the last, not the least, imaging modality. Now we are discussing energy sources. This is the human model 1 HM1 energy source, first lithotripter, which was invented in 1980. Dornier HM3 lithotripter. The Dornier HM3 was the first lithotripter to be widely utilized in the clinical practice. It is a device that features a large water bath for optimum shockwave coupling, fluoroscopic imaging, and ellipsoid reflector as a focusing device with a small aperture and an electrohydraulic shockwave generator. There are currently three types of shockwave generators are available in our setup. We are using with electromagnetic and electrohydraulic, and third one is piezoelectric. First one is electrohydraulic generator. This is the application of high volt. In this electrohydraulic generator, high voltage electrical current between two electrodes, which are separated by a membrane around apart about 1 millimeter apart underwater, causes discharge of a spark. Water around the tip of the electrode is vaporized by the high temperature, resulting in a rapidly expanding gas bubble. This gas bubble, with rapid expansion and then rapid collapse, will produce a shock wave that is focused by a metal reflector shaped as a hemi-ellipsoid. This is a focusing device in this system used in the original Dornier HM3 lithotripter. For the shock wave to be focused onto a calculus, the electrode is placed at one focus, this is termed as F1 of an ellipsoid, and the target kidney stone which is placed on the other focus, that is F2. In this diagram, we can see there is a spark plug, generation of gas bubble, and rapid expansion, then collapse, produce shock wave. This is a brass ellipsoid reflector, the focusing device which direct the shock waves into the target. This is a kidney stone, and it result will breakage of kidney stone. Second one is electromagnetic generator. Two electrically conducting cylindrical plates are separated by a thin membrane of insulating material. There are two electrically conducting cylindrical plates. Passage of electric current through the plates generate a strong magnetic field, which result in the subsequent movement which generates a shock wave. The energy in the shock wave is concentrated onto the target by focusing it with the acoustic lens. In this generator, the focusing device is acoustic lens. This is acoustic lens which focus the target, which focus the shock waves into the target. Advantage: introduction of energy into the patient body over a large skin area, which results in less pain and increased breakage of stone. Third one is the piezoelectric generator. In this, a spherical dish is covered with about 3,000 small ceramic elements, each of which expand rapidly when a high voltage is applied across them. This rapid expansion generates a shock wave. The piezoelectric elements are usually placed inside a spherical dish. This is a spherical dish, and these are piezoelectric elements are placed to permit the convergence of a shock front. Piezoelectric generator result in the generation of a shock wave by non-linear propagation. In this device, we can see piezoelectric small ceramic elements are placed, and these are generating shock waves. There is a focusing device which result in the targeting the kidney stone. The advantages include the focusing accuracy, a long service life, and the possibility of anesthesia-free treatment because the relatively low energy density of the skin entry point of the shock wave. Now we are discussing coupling. Why coupling is important? Coupling is important because it is result in maximize the shock wave which is produced by the generator. It should deliver to the target area. That's why maximizing energy delivery to the stone can be achieved by proper coupling of shock wave lithotripsy generator head to the patient in the air, in a tight manner with minimization of gas bubbles in the coupling media. Because if there are gas bubble in the coupling media, then it will disperse the shock waves in all directions other than the target area. Failure to recognize breaks in coupling can result in unsuccessful stone fragmentation. Coupling is influenced by numerous factors: the type of shock wave lithotripsy machine, which is producing the shock waves, gel used at the patient, generator interface, preferably a greater volume of lower viscosity. And most commonly used gel is ultrasound gel, which we are commonly used in our setup. Method of gel application best to apply to the shock head first. Then there are imaging system. We can visualize the stone by using fluoroscopy, as we all know, and ultrasonography, or we can use the combination of both ultrasonography and fluoroscopy. Now we will discuss the typical shock wave. What is shock wave which we are discussing? A typical pressure pulse at the lithotripter focus F2 has a steep positive pressure front of about 40 megapascal, that is followed by a negative pressure of 10 megapascal. This is a steep positive pressure of around more than 40 megapascal, and this is the negative part of the pulse, negative pressure of minus 10 megapascal. The entire pulse lasts for a duration of 4 microseconds. The ratio of positive to negative peak pressure is approximately 5:1. Now we will discuss the mechanism of stone fragmentation. There are 6 mechanisms. We will discuss briefly one by one.
First one is, if I can interrupt you at this point.
Yes, sir, please.
You go back to the previous slide. Yes. You see, the shape of the curve is different for every energy source. For instance, this may not be a spiky sort of a curve when you use electromagnetic, or you use something called electrohydraulic. But this is spiky whenever you use piezoceramic. So understanding of a pressure wave and the configuration of the pressure wave is very important in understanding the physics behind it. For instance, if you want to break a stone into different fragments, then you can have a stone which has a plateau at the very end of it, which is P plus. But if this plateau is not there and it's a spike, then you will have fragments like a powdery form. So it all depends upon the energy. So this graph is not the same for every energy source. So whenever somebody is selecting an energy source to break a stone, a particular stone, then you look at the Hounsfield units of the stone. That gives you an impression of something called density of the stone. But you also select a particular energy to break a particular stone if you want it in terms of fragments, if you want it in terms of a powder. So this is something which you can add to your slide.
Uh, no, first mechanism is spall fracture. When the shock waves enter the stone, it will be reflected at the site of impedance mismatch. One such location is at distal surface of the stone at the stone fluid is urine interface. As the shock wave is reflected, it is inverted in the phase to tensile negative wave. If the tensile wave exceeds the tensile strength of the stone, then there is a induction of micro cracks that eventually collect and resulting in the stone fragmentation, which is called spallation. Then there is a second mechanism, which is a squeezing, splitting, or circumferential compression. The shock wave advances faster through the stone than in the fluid outside the stone. The difference between these movements, because shock wave advance faster through the hard surface, it produces a circumferential force on the stone, resulting in a tensile stress that is at its maximum of the proximal and distal end of the, and you will see this is the outer surface, and there is another outer, there is inside the stone, and the difference between these two surfaces and these two energies, they will compress the stone and it result in breakage of stone, sequential splitting or compression. Third one is shear stress. Shear waves are generated by the energy source. These produce high shear stress in the stone. Many materials which consist of layers weak in shear, for example, calcium oxalate, it consists of many layers which result in weak bonding. That's why when you apply the shock waves, there is a weak shear stress, a less shear stress, which result in reluctant to breakage of stone. Its tensile strength 5 to 10 times larger than the spall. Fourth one is superfoxing. Uh, Amplification of stresses inside the stone due to geometry of that stone. This can be focused by refraction and diffraction. Refraction means if a wave enters from one medium to another medium and it changes its direction, this is refraction. But when a wave passes from through obstacle, it spread in all directions after passing that obstacle. So we can get the superfoxing from that mechanism. Then there is the cavitation and dynamic fracture. The formation and subsequent dynamic behavior of the bubbles in dynamic fracture process, damage induced by the shock wave during the course of treatment by all mechanism which produced spall fracture or which produced circumferential compression. With these all mechanism results in cavitation and dynamic fracture. This will also result in breakage of stone, and this will also help in breakage of stone. Fragmentation is achieved by erosion and shattering. Cavitational forces result in erosion at the entry and exit sites of shock wave. Shattering results from energy absorption with stress, strain, and shear forces. In this diagram, we can appreciate there is a shock wave when it causes erosion. This is a stone surface, and this is a shattering occurring in the stone. And after second B diagram, we can see erosions can also seen at the other end when the shock wave passes through the stone. So these all mechanisms help in breakage of stone. Energy ramping. Why energy ramping is important? Energy ramping basically.
Just a minute. Before going on to energy ramping, one has to be very clear that all these mechanisms of stone breakage and fracture, as is described thoroughly by Arsalan, they all play their part, but more so is the actual operator who is behind the machine and focusing the machine. For instance, if you focus something, any energy source, to the nucleus of the stone, then you will not have a proper effect doing everything, for instance, like spallation. So you've got to have something at the back of your mind that you plan your procedure and you focus your energy towards the periphery first, and from periphery it has to come to the center. Otherwise, you will have a lot of fragments that are bigger in size, so that they cannot pass through normal
Yes.
ureter. Ureteric lumen is the internal diameter is between 4 to 6 millimeters, maybe up to 1 centimeter, but not beyond. So if anything is greater than that, it cannot pass on its own. So it is kind of a common sense that if you want to break a stone, it should not be broken from the center. It should be broken from the periphery. Now, this if you have got this kind of a common sense in at the back of your mind, and you apply this common sense whenever you use lithotripsy for the purpose of stone breakage, or maybe you are using it in internal lithotripsy when you use a lithoclast, or maybe you are using a laser fiber. You always work your way from the periphery towards center rather than from center towards periphery. Otherwise, there will be no uh, positive effect of your procedure, how efficient you are. Dear Slam.
Yes, yes. Uh, Energy ramping. Why energy ramping is so much important? Ramping is important because ramping up the energy voltage of the device rather than beginning at the maximum energy is one way to minimize the tissue injury and potentially improve the stone breakage. Uh, if we start with slow energy, there will be vasoconstriction, and that result in less complication after ESW or post ESW like hematoma. And secondly, if we will start with the stone, then stone will fragments in smaller pieces rather than large pieces, which results in obstruction in the ureter, as already discussed. Uh, that's why if we increase the energy in a slow way, in a slow manner, then we can achieve this goal of ESW. Now we will discuss the indications. What are the indications of ESWN in renal stone, in ureteric stone, in some cases in bladder stone, in some scenarios. First, we will discuss the indications in the renal stone. Renal stone indications are divided further into two groups: upper and middle mid pole, and then the lower pole. For non-lower pole renal calculus, there are if the size is more than 2 centimeter, then we will go for PNL, as we already know. If the size is less than 2 centimeter, then we will further divide it into two categories. First one is less than 1 centimeter. First choice is ESWL. If ESWL failure, then flexible URS. If URS failure, then go for PNL. But if the stone size is more than 1 centimeter, then we will decide on Hounsfield unit. If Hounsfield unit are less than 1000 and skin to stone distance less than 10 centimeter, then we'll go for ESWL. But if stone size, if stone Hounsfield unit is more than 1000, or cystine stone, or Bushy stone, or skin to stone distance more than 10 centimeter, then go for flexible URS. If it fails, then we will go for PNL. These indications for non-lower pole renal calculus. No symptomatic lower pole renal calculus divided into three categories. First one is if stone size more than 2 centimeter, then probably go for PNL. If stone size is 1 to 2 centimeter, if PNL is contraindicated, no, then go for PNL. But if PNL is contraindicated, then go for flexible URS. But if in stone is the lower pole and stone size is less than 1 centimeter, then further we will have to see the Hounsfield unit skin to stone distance and anatomy. Hounsfield unit if less than 1000, skin to stone distance is less than 10 centimeter, and favorable anatomy, where we will discuss later what is the favorable anatomy for lower pole. And then go for lithotripsy. If Hounsfield unit more than 1000 and skin to stone distance more than 10 centimeter and anatomy is not favorable, then go for URS. No lithotripsy for ureteric stone. Guideline says proximal ureteric stone and distal ureteric stone. For proximal ureteric stone, if stone size is more than 10 millimeter or 1 centimeter, then go for URS. If we couldn't perform URS, then go for lithotripsy. Otherwise, first choice is URS. If stone size is less than 1 centimeter or 10 millimeter, then go. First choice is shock lithotripsy or URS. Either you can go for URS or lithotripsy. For distal ureteric stone, if stone size is more than 1 centimeter, then URS first or second lithotripsy. If stone size is less than 10 centimeter, then lithotripsy or URS. No bladder stone. For bladder stone, we usually go for, we will obviously after getting workup decide on the size. If size more than 2 centimeter, 3 centimeter, then for open procedure or in minimal invasive like laparoscopic or robotic assisted system thoracic. But if are less than 2 centimeter, then go for PUCL. But in some cases, if PUCL is we couldn't perform the PUCL, patient is not fit for anesthesia, and patient has other comorbid, then there is some cases, there is some articles which we have, which will do lithotripsy for bladder stone less than 2 centimeter. Fear of endoscopic procedures not fit for general anesthesia or regional anesthesia, difficult to make lithotomy position. There are some studies which I studied. One study shows 90% patients spontaneous evacuation occurred after removal of Foley. Sample size was, their study was 45 patients they took, and more than 40 patients passes spontaneous stone, and stone size was less than 2 centimeter. 9% developed acute urinary tension, which was treated by recatheterization and second session of ESWA. We will discuss the complications of shockwave lithotripsy. Shockwave lithotripsy complications related to stone fragments, infections, and tissue effects. First, we will discuss related to stone fragments. First, most common are we usually see in the emergency room stain straws, which is 4 to 7%. Second is regrowth of residual fragments. Third is renal colic. Second is infection. You mentioned bacteriuria in non-infectious stone or sepsis. Third one is renal, cardiovascular, and gastrointestinal. Regarding renal, hematoma is maybe asymptomatic or maybe symptomatic. Less than 1% chances of symptomatic, and 4 to 19% chances of 4 to 19% cases hematoma occurs, which is asymptomatic. Cardiovascular dysarrhythmia, it can cause dysarrhythmias, morbid cardiac event. Gastrointestinal bowel perforation, there are case reports regarding liver, spleen, hematoma.
Just a word again.
Yes, sir.
It's about Steinstrasse. You say this complication, Steinstrasse, will always be there if we don't take care of two things. One, we haven't selected a person or a stone with a size of maybe.
Sorry, sir. Sir, आपकी आवाज
जी. So if you select a stone whose size is not of appropriate diameter, it is greater than 1.5 centimeter, maybe in the range of 2 centimeter, then obviously you got to have a bigger amount of sludge. So that sludge has to pass on its own through the narrow lumen of the ureter, as well as pass through the ureteric orifice under gravity. So if you have wrongly selected a stone size, then it will certainly go into Steinstrasse. The second thing is, if you wrongly select a particular energy source, again, you will have bigger fragments. So a bigger fragment will always be there. Maybe bigger fragment, not one fragment, but many fragments, but they are all bigger fragments. So if you want to have something called a powdery form of a stone, then you got to select a particular energy source. So again, if any operator is sitting behind the machine and doesn't know about the actual sine curve of the energy source, then you got to have all these kind of complications. So we will be able to reduce the complication rates if we follow certain important steps, as I have said earlier on, selecting a particular energy and selecting a particular stone size. So these days we have got availability of PNL, micro PNL, mini PNL. So if a stone size is not in the range of 1.5, we shouldn't go towards ESWL. So the rates and the incidence rates of Steinstrasse were there all over the world when there was nothing available in terms of PNL. Now we have got many options.
Yes. There are contraindications regarding ESW, some absolute contraindication: pregnancy, uncorrected blood clotting disorder, non-renal artery stenosis, acute urinary tract infection or urosepsis, uncorrected obstruction distal to the stone, abdominal aortic aneurysm. There are some relative contraindication: uncontrolled hypertension, morbid obesity, renal ectopy or malformation, renal insufficiency, and cardiac pacemaker. There are some special problems in stone removal. For example, if there is a stone in calyceal diverticulum and there is we can apply, we can go for ESWL if calyceal neck, calyceal diverticular neck is open. The horseshoe kidney, they can also be treated, but passage of fragments after ESWL might be very poor. But in stone in pelvic kidney, it can also be treated by ESWL, RIRS. And stone formed in the continent reservoir, each stone must be considered and treated individually. Now we will discuss the clinical parameters that may affect outcome of ESWL. The outcome of ESWL can be enhanced in many ways. Patient selection plays an important role, as sir already discussed this, and factors to be considered include body habitus, stone burden, anatomical location, stone density measured by non-contrast CT scan, stone to skin to stone distance.
And one more thing,
Yes, sir, sorry.
and that is again the operator. You see, if you start your machine with a focus somewhere else and you don't refocus your target, then you will miss the whole point. So it's all about refocusing, because whenever the energy comes into play, it strikes the stone, it will move the stone somewhere. So the bigger the area available for the stone, maybe in the renal pelvis, the bigger is the availability of the chance of having lost the stone from the path of energy convergence, and that is the focal point, the F2. So you got to focus your stone towards F2. If you are not doing it, you are not in the habit of refocusing. Maybe you have done your procedure 1 hour, maybe 45 minutes, but stone will not break. Stone will not break just because of the reason that any kind of energy is present in the vicinity. Stone will break when that vicinity is closed down to a point, and that is F2. It should be on the stone. It shouldn't be anywhere else. Otherwise, you will have a lot of other things. For instance, as it has been said, um, uh, complications like hematoma formation. So you got to have a kind of an obsession, and that is on the part of any operator. And it should be a doctor. It shouldn't be a technician, because technicians will not have that kind of obsession or maybe commitment. So it's the commitment of the whole team, and it should be a doctor. Anywhere in the world, lithotripsies are run by doctors, not by technicians.
Body habitus. Poor outcome of shockwave lithotripsy have been attributed to obesity. Appropriately positioning patient with high body mass index to target the stone can be challenging, as the focal length of most lithotripters is in the 15 centimeter range. If skin to stone distance is more than 10 centimeter, then we will get the poor result. Uh, then Ackerman and colleagues multivariate analysis reported finding that BMI was a significant negative predictor of a stone-free outcome following ESW. Any gross skeletal abnormality, contracture, excessive weight may severely limit or preclude. Then is the stone burden. Stone burden plays a significant role in predicting the outcome of ESWL. Even for patients with non-staghorn calculi. As stone size increases, the likelihood of successful outcome decreases. Uh, EAU and AUA guidelines do not recommend shock wave lithotripsy as primary treatment for stone larger than 2 centimeter in size. Then there is stone composition. Stones have different composition very widely with regard to their fragility. Calcium hydrogen phosphate, cysteine, and calcium oxalate monohydrate stones are the most resistant stone for ESWL. Joseph and colleagues reported a significantly reduced stone-free rates of 54.5% with shock lithotripsy for calculi greater than 1,000 Hounsfield units. In contrast, they found a 100% successful rate if stone were less than 500 Hounsfield units. For stones between 500 and 1,000, the clearance rate was 85.7%. Then there is a triple D score. Recently, Parikh and colleagues developed city-based metric scoring system. The triple D score incorporates three metrics: stone density, stone size, volume to dimension, and skin to stone distance to augment the prediction of shock wave lithotripsy treatment outcome. They established a cutoff of less than 150 microliter for ellipsoid stone volume, less than 12 centimeter for skin to stone distance, and less than 600 Hounsfield units per stone density. The triple D score of 0, 1, and 2, and 3 correlated with shock wave lithotripsy success rate of 21%. If score is 0, if score is 1, 41, if 2, 73, and if 3, then 96.1%. There is another important factor which will predict the results of shock wave lithotripsy. This is a stone, that is stone location. Stone location is an anti-influential factor for the outcome of shock wave lithotripsy. Attaining a stone-free status with lower pole calculi, even if fragmentation occurs, can be challenging. We can see in this diagram there is a infundibular width, there is an infundibular length, and there is an infundibulopelvic angle. If the angle is more acute, then there are less chances to pass the stone after fragmentation from lower pole to ureter. Infundibular angle plus infundibular width and length are anatomical factors that can alter the success rate for treatment of lower pole calculi with shock wave lithotripsy. In order to decide for ESWL treatment of lower pole stone, the favorable factor should exist. Infundibulopelvic angle more than 45.
Just a moment, Ruslan.
Yes, sir.
This phenomena of infundibulopelvic angle, again, it is very important. Just because of the reason that earlier, 10 years back, 15 years back, or maybe more so, when we were residents, it was a kind of a norm that if there is a stone and it is in the lower pole, lower calyx, and it is not obstructing, there is no hydronephrosis, then the norm was it should be left behind. There is no problem, because if you break it, jump up and come down on its own. But now the bottom line is if there is a stone, it has to be cleared. There is no point in just leaving behind a stone, maybe in a fragmented fashion, and saying that it is not causing obstruction, so just let it be there. So if there is a stone, it has to be cleared in toto. Now, then is the importance occurs of this infundibulopelvic angle. Because if you are selecting something for lithotripsy and the infundibulopelvic angle is less than 45, the stone will break, it will not come up. come down. First, it has to jump up and then down. So for these kind of stones, now the kind of standard operating procedure is to select some kind of a PNL. It is not ESWL nowadays. So you see the energy source and the technology is there, but the indication is now changing. The indication is changing as well as some of the physics and geometry has to be taken into consideration. It is not the impression of a single person that it will or it will not come out. It has to be something written down, some kind of a formula, some kind of mathematical notation. So this is what the normality these days is.
Uh, Anyone from the audience can describe what is this? What is the X-ray shows? No one. Sorry, you can ask.
There is one raised hand.
Yes.
This image shows the collection of stones in the urethric part, which is what these stones stacking up of stones after electrolysis.
Right. So this might be a post-lithotripsy Steinstraße.
Yes, sir. This is the scenario was in that typical specific sequence is that a patient after ESWR presented in ER with the complaint of pain on left side, and after investigation, and there's a history of ESWR 1 day back, and after investigation, this CT scan showed strain loss effect. There is a fragmented stone which are obstructing in the distal ureter on the left side.
So the second question should be, what should be done for this kind of Steinstraße?
Should be the middle. Yes, sir.
So anybody from the audience? Omer. Hydration, and then wait for how long? This might be a single kidney, and this is an obstructed system. Hydration for how long?
1 week.
Patient might go into renal failure. Patient is in colic since there is an obstruction. Patient will not come back to you because you haven't done any justice to his agony. He is in a, or she might be in a lot of pain. So there has to be something very acutely done to this patient. For instance, if this is kind of obstruction in the distal ureter, if you do an ultrasound, there might be hydroureter, there might be hydronephrosis. So you can't just leave it behind for 1 week. 1 week is too long a period.
Sir, we will wait for 1 week. There is no hydro or
You can you predict that there shouldn't be any hydro with this kind of obstruction? Again, you must put all your efforts in placing yourself in the place of the patient.
yes.
If you are a patient with this stone, you won't allow anyone to do anything for the next 7 days. You want everybody to do anything just now, 5 minutes, 10 minutes. Patient will be in a lot of pain with this kind of problem. First step would be what? Patient comes to you with this picture in emergency. This picture is taken in say 5 minutes back, maybe 10 minutes back, but the patient has gone 12 hours back, one session of lithotripsy. What would you do in the next 15 minutes for him? And any decompression, degestant, bladder to empty करें. Right? You should have all have a kind of a roadmap for every kind of complication the patient presents to you in emergency. So this is a common day practice. We all have these patients every day, perhaps, maybe the other day, whenever somebody is there in the ER. So you shouldn't ask for any seniors' help, because seniors come at a time, maybe not at the same moment when the patient is there with you. So yes, I vouch for this thing that you must do analgesia. The second thing is, you must be able to understand that if there is hydronephrosis and there is a level of hydronephrosis which is like mild, more than mild, it is in the range of moderate to severe, the person needs immediate treatment, immediate relief, and that relief is always done by putting in a PCN in our case. Now, to put in a DJ stent, you need a lot of other things. For instance, a GA fitness. For instance, a person with an empty stomach. So all these things take a little bit of time. Something which can be done for this patient right then and there is called PCN. For PCN, you need one thing only, and that is an ultrasound picture and a clotting profile, PTA, done in 5 minutes, right? You can plan then. For instance, maybe somebody will say that the patient can be done in prone position. You will do another session of ESWL by filling up the bladder and then doing ESWL for this Steinestrasse. It will clear on its own. Maybe the other person comes into the room who is a very enthusiastic person. He will tell you that no, this patient should be for URS. I'll put in a URS, clear off all the fragments, put in a DJ stent afterwards, taking out the DJ stent after maybe 2, 3 weeks. So everybody has got his own opinion, but the opinion should be first relieving the kind of agony the patient is in.
Sir,
Ji.
for such a condition like this stent strategy, is a pre-op DJ stent placing in such a condition is not helpful. Like the stone is 1.5 centimeter. So in which condition we can place a DJ stent pre-op or PSW?
Whenever you are selecting something which is on the borderline, for instance, if there is a stone which is on the borderline, that is 1.5 centimeter, so as I've said earlier on, a bigger the stone, the bigger will be the sludge, the more will be the chance of having Steinestrasse. So if it is something which relates to a lot of other things, for instance, stone size, for instance, peristaltic movement of the ureter, for instance, proper selection of energy source, and the other thing is the operator who has who is breaking the stone in what fashion. If the stones are broken down into different kind of pieces here and there, those pieces will always stuck somewhere. But if it is a properly selected stone size, if it is a properly selected energy source, if it's a properly done ESWL session with refocusing every now and then, you will not have Steinestrasse. So if you are in a habit of putting in a DJ stent before every stone fragmentation, every stone ESWL, then this is a wrong approach. But obviously, there are certain conditions. For instance, there is contraindication for anesthesia. You got to have ESWL, which is done under no anesthesia, and the stone is maybe 1.5 to 2 centimeter. So you are thinking that it will cause a lot of sludge. You are thinking that there is no other procedure available. Then you will first attempt DJ stent so that there is no uh, sort of a blockade of the system, and the patient will remain pain-free at least. If there is a sludge, it will cause Steinestrasse, but that can be taken care of later. It will not cause obstruction. It will not cause hydronephrosis.
We improve the outcome, learnings. Our usual behavior in providing ESWL is setting of frequency of one and then ramping up the tunes. So, does the increase in frequency from shifting it from 1 to 1.5 hertz has the effect on stone fragmentation or the size of the stone fragment? So, because we are treating every stone with a 1 hertz frequency. So, by changing the frequency and increasing the power, does it have a difference on the size of the fragments and
It is known as burst lithotripsy.
Yes.
Manohar Saab.
For the first question which was asked before, the selection of cases in which we put a DGA stent or not put a DGA stent. If the kidney is one is a single functioning kidney, then and stone is in the renal pelvis or in the upper part of the kidney, upper calyx. So usually it's a more chance to have fragments, and these fragments will pass out in a rush and cause a and cause a time stressing. So for the selection of cases in the outpatient department, we usually select such patient if there's one kidney or stone in the renal pelvis or either 1.5 or 1.6 stomacher. So there is more chance if the all stone we don't know the density of the stone before the ESWL. So and for the ESWL, it is practice to have low energy starting from the lowest energy and gradually increase and observe frequently after 300, 500 shocks. You must see the position, either patient is moving or stone is moving or not. And stone is in 0 degree and 30 degree. It should be in the target position, right? So, and always in the start from the lower energy and relieve the pain in is the way. So this is the practice usually we have to.
There are studies, they compared both the groups with high energy and high rate, with low energy and low rate, and their conclusion was that you get lesser size fragments with the low energy and low rate. So what is your take about
This is normally it is a practice always in a low energy and low rate. Low rate means not more than 90 or 60 to 70 is enough. And we don't know the density of the stones before ESW. So we can't say whether this stone will fragment totally or partially, or it won't affect. Usually calcium oxalate monohydrate stones are hard. So it won't affect sometime in one session.
So the recommendation these days is ramping. So ramping is what that, as you have said earlier on. We all must understand the physics and the philosophy behind all these that we have been discussing in order to achieve what we want to achieve, and that is not only breakage of a stone but also clearance of a stone, and that is very important. You break the stone and the stone is dislodged from its position but stuck somewhere down below. It will cause more harm to the patient, and the patient needs not only clearance of the stone but also avoidance of all the complications that can occur. Yes, you want to say something, Sam?
Sir, after ESWL to facilitate stone passage, there is PDI. It is written PDI therapy, percussion, diuresis, and inversion. So, how effective are these maneuvers, or how can we counsel the patient about these percussion, diuresis? Diuresis is simple. How effective are they?
Manoj sir, do you have anything to say about it? I don't know whether they are still kind of recommendations, inversion and percussion.
It was tried previously, but won't have the good results. We can't say the results of the outcome.
Conclusion: in the era of minimal invasive surgery, ESWL, despite its age, still plays a role of primary relevance for the properly selected patient. ESW is a well-tolerated, non-invasive procedure that produces reasonable stone clearance of upper urinary calculi while offering with low morbidity rates. The mortality will stay in this era of minimal invasive surgery in very selected patient and weak players. Thank you, sir.